history, and actually most of the time, history is enough to diagnose classical, straightforward asthma, and you need to complement this with spirometry. Okay, so we have to do spirometry, yes, but history, most of the time, in typical, classic, straightforward, simple asthma, history is most of the time is can't tell you whether the patient has asthma or doesn't have asthma. So the symptoms, cough, chest tightness, wheezing, and dyspnea, and cough, chest tightness, wheezing, and shortness of breath. But remember, this shouldn't be present at the same time with the same patient. So some patients have only cough, some patients have only chest tightness, some patients have only dyspnea, some patients are wheezing, and some patients have more than two, or more organ, or two or three, or combination with them. Or some patients have the symptom at one attack, they have symptom this today, cough, a few months later they have chest tightness, wheezing, and all this. So that are symptoms, but it should not be present at the same time with the same patient. So some patients have only cough and asthma. Some patients have only chest tightness during the sleep, for example, or wheezing and all these things. So these are typical symptoms, but not all present at the same time on the same patient. So age of onset is very important. Diurnal variations, commonly asthma is worsening at night and early morning. So it's very common questions, especially in mild to moderate asthma or newly diagnosed patient with asthma with night symptoms. So during the night have cough, have wheezing, wake up at night with chest tightness. During the day is okay. But with the time when the asthma patients progress or become more severe and controlled, they have 21 hours, so nothing seems to be at night. Seasonal variation is very important, especially in these weeks nowadays. And most of your patients, they are all there, they are okay, and they are controlled, they are asymptomatic, they stop the hair, and some of them. Then early winter, they start to have viral infection. And now it's very common, it's not everybody has viral infection now. Influenza A. 99% of the viral infection now is influenza A, and they get flu and they get their asthma symptoms. And then ask if the patient has a chronic cough, consider cough and asthma is very important. And patient history is on insufficient sensitivity of asthma symptoms. So most of the time, classical simple straightforward asthma history is more than enough to diagnose asthma. Asthma during childhood is very important. So if a patient, adult patient come to you, especially if he's teenager or younger, middle age, don't ask him the duration of asthma. Is this having asthma during childhood and is not? Very important, there's other comorbidities. It's very common to see a lot of patients with asthma. They don't have asthma only, they have asthma with other comorbidities. And very, very common, like rhinos, allergic rhinitis, nasal polyposis, chronic sinusitis. It's almost up to 70% of patients with asthma, they have concomitant nasal polyposis, chronic sinusitis as well. Atopic dermatitis is common because of all allergic disease, but I think about 20 to 30% of asthma patients have atopic dermatitis. But always something forgettable. We don't even ask the patient about different symptoms. It's very common in patients with asthma, and often asymptomatic, or patient have mild symptoms, or have infrequent symptoms 1 or twice per week or per month. And you see a patient who is using, like, running in many doctors, many hospitals, many clinics, using all type of inhalers, and nobody asks him about different symptoms. The moment they put him on UBI for like minimum 6 weeks or 8 weeks, they get rid of all inhaler and the asthma control. So if you see a difficult to control asthma, you're using multiple inhalers, they're running in different hospitals, different clinics, think about girls, treat girls. Okay, even patient has minimum symptoms or no symptoms. Some patients even have symptoms but deny it because they think there is no link between them. They won't ask a question. Sometimes you ask the patient about get symptoms and he has asthma, he's much shocked because why asking about this? No relation. The patient thinks like this. But actually for us, you have to ask the patient about asthma. Allergic bronchopulmonary tuberculosis, this is something that one person asthma patient, you may have not asthma as ABPA. This is, you need bilateral central bronchitis, you need CT scan, you need allergic bronchitis, antibodies, you need allergic bronchitis. It's uncommon, but it's always not think about it. Sleep apnea is very important, concomitant other comorbidities, especially if they are obese. And we never control asthma if the patient still has obstructive sleep apnea and not diagnosed, and diagnosed or is not on CPAP or need treatment for sleep. Ask them about asthma medications, current medications, type and dose and duration, past medications, and smoke therapy. So ask a patient, some patients come to you with naive patient, never any medications. Some patients they come to, they are only on saga or Ventolin addicts or dependents on an almost daily basis for weeks, months, even years. Okay? And so patient already inhaled corticosteroid in combination with them and still uncontrolled. And when you see the patient with already inhalers and they are controlled, the first one to ask yourself about compliance adherence to inhalers. It is the most common cause of uncontrolled asthma is adherence or poor continuous exposure or poor education and poor technique. So asthma education, technique, adherence to inhaler, this is the first basic step. You have to evaluate the patient with uncontrolled chronic asthma. Some medication may worse asthma or triggering cough like ACI, angiotensin enzymes, aspirin or NSAID, or sometimes beta blocker oral or intraocular. Uncommon, but it's all you have to think about it. So so you have to review patient medications. It's one if any of these medication, it may cause cough and worsening asthma symptoms.